and able to be understood. It's really not American English, thank God. It's Australian English, so it's not quite English, but it's getting there. I have been involved with metabolic muscle diseases for more years than I would like to tell you, but very much over the last 40 years, and started at Vanderbilt University in Nashville, Tennessee, when I went there for a 3-year postgraduate course and research, and then got stuck in the United States till now. And when you start having grandchildren, you can't move anywhere else. So that's where I am. Pompe disease, really, we've come a long way in understanding it, and it's relatively controversial. And I think that everybody should have an open mind about all of these complex metabolic conditions, and to be able to ultimately decide how you're going to treat the patient is really going to depend on the response of the patient, ultimately. Everything else is really irrelevant. And so the role of nutrition and exercise in minimizing the pathogenic effect of autophagy in late-onset disease. And Linda Ballone is my nurse who's been working with me for about 30 years, is not working with me full-time now. She went on to doing cancer therapy, mainly because of lack of funding for metabolic diseases. And this is the unfortunate thing in the United States, where rare conditions that don't bring in adequate funds are not well subsidized. And I'm not going to talk about that aspect anymore. The classification of Pompe disease is divided into 3 sections. The infantile form, where there is usually less than 0.5% enzyme activity, but by definition less than 1% activity, consists of cardiomyopathy, myopathy, respiratory failure, and these patients die within the first year of life, or certainly within the first 1.5 years. And we've actually identified a less severe infantile form where they seem to be able to survive a bit longer if they are treated early enough. But basically, the outlook up till enzyme replacement therapy, was very, very dismal. Then there's the group of late-onset Pompe disease patients, the childhood which present within the first year or 2 of life, and juvenile who present in late childhood, early adolescence, about 12 or 13 years of age, don't have cardiomyopathy. They only have skeletal myopathy, respiratory failure, and they die in adolescence or early adulthood. That's the natural history. The third group is the adult onset, who seem to do reasonably well during childhood, although they're not able to keep up with other people in a lot of aspects, particularly as they go through puberty and into adolescence. They have also no cardiomyopathy, but they have myopathy, respiratory failure, and over 50% have demise early. The age of onset and enzyme activity of late onset patients, as defined by HERS back in '89, and this varies fairly widely, but usually the onset is less than 2 years, with 1 to 5% enzyme activity, 2 to 15% in juvenile. But juvenile are really not 2 to 15, that's incorrect. It's really about 6 or 7 to 15%, and they present at 4 to 8 years of age. And then the adult group present after 15, and they usually have 8 to 14% enzyme activity. The histology of the infantile patients are very, I don't have a pointer, but very clearly illustrated here in this electron microscopy, where basically you're looking at all of these areas which are glycogen, and these areas are skeletal muscle, minimal skeletal muscle in infantile Pompe disease, and there's no way that they can actually function and go on and survive. This is the histology of the late onset patients, where you can see normal skeletal muscle pathology with intervening high glycogen deposition, but still there is adequate amounts of skeletal muscle to be functional. This is one of the pieces of work that was still done at Vanderbilt University, and this was very critical information. And if you look at the, has anybody got a pointer by any chance? Or? No. I'm going to donate a pointer to this department. Oh, if I do it here? Yeah. Oh, okay, that's great. If you see the valine, leucine, and isoleucine, the branch chain amino acids, the continuous line is the normal controls, and they rise 2 to 3-fold over a 4 to 5 hour period from baseline and stay up for about 4 to 5 hours and then gradually come down. Whereas valine, leucine, and isoleucine, they go up rapidly and actually go up 2 to 3-fold, but come down very rapidly, and they're back to baseline within 3 to 4 hours, and certainly by 5 hours they're back to baseline. The other interesting amino acid is alanine, which is not a branch chain amino acid, and which normally is not associated with muscle protein synthesis, but on the other hand is associated with gluconeogenic substrate. Alanine goes up within the first hour, and then when the patient has been fasting, is not only comes down rapidly, but more rapidly than the other three, and actually drops below baseline by 4 to 5 hours. So that this indicates that the patient can be in equilibrium for about 3 hours after some protein intake, and after 3 hours they are already in a negative nitrogen balance, and they're going to be utilizing alanine from whatever source is available. This is an exogenous source when we give it to them, but the other source of alanine, of course, is skeletal muscle. And what happens is that alanine is a very important amino acid, and we were just talking about it at lunchtime today, and it actually is utilized very rapidly after 3 to 4 hours and causes depletion from skeletal muscle of the patient, which is the last thing you want to do. You want to try and keep up the positive nitrogen balance so that you're not breaking down skeletal muscle, but that's what will normally happen. This was a overnight fast in a 3-year-old Pompe patient, a fairly severe patient from the Midwest, and we just fasted the patient overnight, which the patient does at home every night, and we monitored the child from about 9 or 10 p.m. For 11 and 13 and a half hours. And we see the glucose level dropping from 91, which is within the normal range, down to 58, which is already well below the normal range, and millimoles also well below the acceptable normal range. But what happens at the same time is that the alanine level, which is in this patient was 192, which is just at the baseline of a satisfactory level, dropped to 59. Now, I've been looking at amino acids and alanine in lots of muscle diseases, McArdle's disease and PFK deficiency and fatty acid oxidation defects and so on. I never found an alanine to drop so profoundly as we saw in this child, indicating that there's a very, very short period before they become proteolytic, breaking down their own protein, and therefore trying to supply alanine, but probably inadequately in this child. By the way, if there are any questions, just stop me and raise your hand and so on. This was a study on an 18-year-old Pompe patient who had been diagnosed at puberty, just after puberty, and we did this in collaboration with Maury Heyman from the Yale. I'm gradually getting used to the system. No, that's fine. Thanks very much. Right. This will be a great memento. Maury Heyman was at Yale at that time, and then he subsequently has moved on to Texas. So using tritiated alpha-ketoisocaproic acid and C14 leucine in normal controls, the total leucine carbon flux was about 2, and we see that in this patient who was starting to have considerable symptoms, it was more or less 50% greater. We repeated it 6 months later, and again it was 50% greater. Leucine oxidation, which is relatively low in normal people, was 3-fold higher. So indicating that branched chain amino acids are being utilized all the time over that period of time that we were monitoring this patient, 1.22 to 1.15 micromoles per kilogram per minute. So this was still in the late 1970s when I was at Vanderbilt. We came up with the following treatment based on what we had found in these patients to give them high protein and exercise therapy for these patients. High protein, low carbohydrate nutrition, not terribly low. In other words, dropping it from about the normal American intake of 60% carbohydrate down to about 40% carbohydrate, not down to an Atkins-like diet, which is about 20%, which is inadequate, but high protein, 35 to 40% carbohydrate, and submaximal daily aerobic exercise. And in addition, you supplement with alanine because of what we saw in that patient, that 3-year-old, 1 gram 4 times a day. A very critical thing to make sure that they don't have weight loss. If you see that they're losing weight in these patients, they're not just losing weight, which a lot of Americans need to do, but they're losing muscle mass at the same time. And you've got to be very careful monitoring their body composition and to be sure that you're not actually losing lean body mass. Treat infections rapidly and intensely. And this is very, very critical. Pediatricians generally don't appreciate it, but when a Pompe patient gets a viral infection or any other infection, they need to be admitted to hospital immediately and to be monitored to see what their CK levels are, and particularly what their metabolic status is and their amino acids and their glucose and so on, to make sure that they are treated adequately. And you treat them, they can't move, they're fully disabled, and then within 24 hours they're up and moving if you give them intravenous protein and amino acids. And we had one child whose older sibling has Pompe disease, and this child was doing very well. The younger child was doing very well, was about 4 or 5 years of age, and developed some viral infection. It was New Year's Day or Christmas Day, I don't remember which one, but it was in December, and they all know to call me to identify what's happening. And there was a doctor who was replacing another doctor at home, didn't call me. This child didn't survive that night, and the next morning we found out that the child had died. And so that's how rapid it can be. And so I tell these patients, particularly the young ones, they need to be admitted immediately to monitor, because what happened is another sibling had a viral infection, and so the doctor thought, well, this kid has got a viral infection, we'll see how he goes over Saturday and Sunday, and if he's any worse, we'll contact the doctor. But that's not the case with Pompe disease, and particularly in a young patient. So you've got to be very proactive. Here we see the sort of generalized situation that exists in fuel source in normal muscle. Glycogen is the anaerobic glycolysis down to glucose 6-phosphate and pyruvate, and then to acetyl-CoA, which is the critical factor in the TCA cycle. Fatty acids produce acetyl-CoA and also produce C3 in the process along along this pathway here, and then they enter the TCA cycle. 4 carbon in oxalic acid to acetyl-CoA to citrate, and then along this pathway to ATP. And amino acids produce protein synthesis, and that's what amino acids are normally used for, whereas glycogen and fatty acids are utilized as source of fuel and in the form of ATP. Fuel source in Pompe disease with high protein and exercise therapy, because of the blocking glycolytic pathway along here, we decrease the carbohydrate, as I mentioned, down to about 40% of intake to glucose 6-phosphate, and glucose comes in there to pyruvate and acetyl-CoA and TCA cycle and the electron transport chain, which I forgot to mention before. Fatty acids come in at this point, and by aerobic exercise increases utilization of fatty acids as fuel, resulting in protein sparing. Otherwise, this protein here is going to be broken down to amino acids, producing alanine to pyruvate. So the two factors that will protect the amino acids so that you can go on to protein synthesis is increasing exogenous protein and increasing aerobic exercise, and so the fatty acids are resulting in protein sparing. And this is just a general reminder of what the Walton scale of muscle function, which was established by Walton in England for the regular muscular dystrophy patients. And preclinical is normal. 1 is walks normally but unable to run freely, detectable defect in gait and posture, climbs stairs without using the rail, and 3 is climb stairs but only with the rail, and then decreasing ability 4 to 6, and ultimately ending up in a wheelchair in the scale of 7 by the Walton scale in what was originally used for Duchenne patients, but it's very appropriate elsewhere. So this was a study by La Thorette, who is from France or Spain, I think France, back in 2000, and we see here the grade of Walton scale and starts off at 0 normal, so none of them are normal, but 1 very mild involvement and relatively rapid deterioration over the first 12 years there, and then here. But this is the older patients that presented in the 20s and 30s and progressively deteriorating up to 6 and 7. We turned it around because we thought going up doesn't seem right. If you're deteriorating, you've got to go down. And we turned it upside down, and this is the response of our patients. Muscle function in compliant Pompe patients, the Walton scale over years. And this is before we ever saw them, over 20, 15, 10, 5 years, and they progressively deteriorated. And this is 5 to 10 years. This was published in 2007, so we're looking at nearly 7 or 8 years since then. And these patients plateaued out. Some of them improved, and some of them improved quite extensively over the following years. So an update on the pathogenesis of Pompe disease over the 30 or 40 years that I've been involved in it really went from one concept to an additional concept to a further additional concept. The first one was back in the 1960s, 1970s. It was all due to glycogen accumulation in the lysosomes and causing myofibrillar disruption. And we introduced amino acids, but the reason for introducing it was because there's increased utilization of amino acids causing muscle protein degradation, as we saw previously with the alanine level going right down to 50. Another factor is the intra and extra lysosomal collection of degenerated organelles and mitochondria causes functional impairment of lysosomes, so that the lysosomes need to take up fats and glycogen and protein, and that was getting blocked, and therefore the simple molecules of glucose, amino acids, and fatty acids were not being produced, and therefore any fasting that occurred was actually catabolic or proteolytic and breaking down protein of the muscle. And then Nina Rabin in 2005 from the NIH, who's doing some excellent work in the mouse model, showed that there is massive accumulation of autophagic vacuoles which causes myofibrillar disorganization. Now, these autophagic vacuoles had been identified for 30 or 40 years. Everybody saw them. They saw glycogen in the muscle. They saw autophagic vacuoles in the muscle. Everybody talked about the fact that glycogen was causing the problem. Nobody understood what was happening due to the autophagic vacuoles. In 2007, there was a revelation occurred. It was like somebody had just discovered the Bible a few years ago. Now they discovered autophagic vacuoles. And autophagic vacuoles is really the most powerful catabolic aspect of Pompe disease. Autophagy and muscular dystrophies, maintenance of muscle homeostasis is finely regulated by the balance between catabolic and anabolic processes. Autophagy, as the Americans call it, is a catabolic process that degrades protein aggregation and damaged organelles through the fusion between autophagosomes and lysosomes. This is the normal process that occurs, and if you're fasting for 24, 36 hours, your glucose, circulating glucose levels are maintained by the process of autophagy. You take glycogen, goes into the lysosomes, The lysosomes break down the glycogen to glucose, and a normal person can fast 72 hours and the glucose levels remain normoglycemic throughout that process. They don't drop to 40 and 50 and so on. And that's all due to the process of autophagic vacuoles. Proper regulation of autophagic vacuole is fundamental for homeostasis of skeletal muscles during physiological situations and in response to fasting. Effective as well as excessive autophagy is harmful for muscle health and is pathogenic in several muscle diseases, but particularly in Pompe disease, where it's really the most critical factor. And so there are different types of autophagy. There's the normal macro autophagy, which we see here, the micro autophagy, which is illustrated here, and the chaperone-mediated autophagy, where there's special chaperones that are utilized in unfolding substrate protein to allow it to get into the lysosome. But if we follow the classical macroautophagy, here we've got various organelles that are needing to be broken down, and they are protein and glycogen and so on, and mitochondria. They are taken up into this double membrane autophagosome, and they're broken down when they merge with the lysosome, and they produce the simple substrates of simple products, not substrates, the simple products of glucose, amino acids, and fatty acids, but particularly glucose. So the proposed model for lysosomal storage diseases is very simple idea of enzyme deficiency of the lysosome, accumulation of metabolites in lysosome, defective autophagosome and lysosome fusion, impairment of autophagy, and you end up with breakdown in tissue or muscle breakdown. And the concept is really a very general one, where you get this accumulation of metabolites in lysosomes where there is actually a blockage in lysosomal function. Autophagy is a double-edged sword for muscle function. It has a beneficial and it has a detrimental effect. During fasting, autophagy removes damaged complex organelles that are transferred to lysosomes to provide necessary simple nutrients, amino acids, glucose, and fatty acids. And the detrimental aspect is excess autophagy causes apoptosis and atrophy, resulting in muscular fiber disruption. And on the other hand, too little autophagy causes weakness and degeneration by accumulation of damaged protein and dysfunctional organelles. So how do we overcome either this process where you've got excess autophagy, or you've got too little autophagy and you end up accumulating autophagic vacuoles in your cytoplasm and not being effective in the lysosomes? So we came up with the idea that nutrition inhibits autophagy in juvenile Pompe disease. And one gets to this conclusion. It didn't come to me as a revelation overnight. It came to me over a number of years, and we'll get to the particular patient who taught it to me. And patients teach us more than we realize, but you've got to keep your eyes open and your mind open to see how things are developing. Long-term fasting causes high rate of autophagosome formation in normal skeletal muscle, as I mentioned. And because of dysfunctional muscle lysosomes, Pompe patients fail to generate simple nutrient compounds when fasting. That is, after about 3 to 4 hours, like we saw in that 3-year-old, stimulating increased autophagy in an attempt to compensate for lack of simple nutrient compounds and the block of basic amino acids, particularly gluconeogenic amino acids like alanine. Various biotechnological techniques, including special enzymology, stem cell replacement, chaperones, and gene replacement therapy, have failed to reduce the autophagy. There are certain benefits from the enzyme replacement finally getting in, particularly if you give it in conjunction with high protein and low carbohydrate and conditioning exercise. High protein and exercise therapy plus nocturnal enteral feeding provides simple nutrient compounds minimizing autophagic generation. So if you give fuel to these patients, particularly in the form of high protein plus alanine, and you exercise them during the day, you give them nutrition every 3 hours, then you gradually get rid of these autophagic vacuoles. And it's a very simple idea, but it really is very, very effective, and took us a long time to understand what's going on. We finally published a paper in Muscle and Nerve in 2006, benign course of glycogen storage disease, type 2B in two brothers, nature or nurture. We were compelled to use that nature or nurture in Muscle and Nerve. We had submitted it to 6 journals, and all of them turned it down because they didn't believe the results. Finally, Billy DeMoro, who's head of a wonderful person and great scientist, head of the neuropathology lab, he was going up the wall. I'm used to being turned down. It's routine for me to be turned down by papers because they think it's out of whack. But Billy, he's not used to being turned down, and finally got Muscle and Nerve to allow us to publish it. And we had to revise the whole paper and take away our ideas that what we thought was happening. As you can tell from my comments, it was very personally traumatic. This is the story. Muscle biopsy results in 2 juvenile Pompe disease patients. There were 2 factors about these 2 patients that were critical. One was the fact that the family lives about 2 to 3 hours away from New York, so they were able to come in and out as necessary. The other was that they have a remarkable, sensible mother who didn't leave any stone unturned to try and help getting these boys into a satisfactory situation. Mothers are critical when you've got a muscle disease. They're critical for other reasons, but for muscle disease, mostly. Anyhow, this is the older brother at age 2. He was referred to us. His acid maltase was 0.9 micromoles per milliunits alpha glucosidase. So this was about 2 to 3%. Neutral maltase was 9.2, which is within the normal range, and the glycogen was 5.4% in the muscle tissue. And we'll come back to him in a minute, but the parents, who were religious Catholics, they didn't want to have any further children because they didn't want to make a decision of amniocentesis and perhaps interrupt the pregnancy. And they waited for 10 years, and then they finally had another child. And this child, AD, was born when the older brother was 12, when VD was 12, because he was doing so well. And the diagnosis on AD was made at 6 weeks of age. By this time, we were able to make it on blood and skin fibroblasts, and he was diagnosed at that point in time. We'll come back to this levels later on, because this biopsy was done at 7 years of age. And then VD had another biopsy when AD was 7, because AD was doing so well. we went and we did another biopsy on VD. Again, his AM was down here, his neutral maltase was down here, and his glycogen had normalized to 1.66 because he had been on treatment for about 10 years. This is VD's original biopsy at 2 years, and as you can see, it's full of glycogen deposition. These white areas and these discolored areas are autophagic vacuoles, and throughout the muscle, and these are normal muscle tissues, relatively about 50% of normal, the rest being affected by autophagic vacuoles. This is the same boy at this biopsy, and the acid phosphatase is indicative of autophagic vacuoles and other necrosis throughout his biopsy. So we come back to the boys, and they're treated with high protein and nocturnal enteral feeding of high protein. The older brother was put on to this at 2 years of age, was diagnosed. He had 3% enzyme activity. He was on high protein and exercise from 2 years. He didn't like the protein. He wasn't taking it, and the mother would come every 6 months or more frequently, and sometimes he was hospitalized with whatever problem, gastroenteritis. Boom, he would really drop down and couldn't get out of bed and so on, and she would rush him in. And we started nocturnal enteral feeding at 4 years by gastrostomy. The younger brother was born 10 years later, and the younger brother was diagnosed at 6 weeks by an elevated CK, and Pompe disease was by fibroblasts, as I mentioned. High protein from 6 weeks, high protein and exercise therapy, and nocturnal enteral feeding from 1 year. When Mum came to me and said, put in a gastrostomy, I said, yes, we're ready. And then the younger brother was the best soccer player in the group, and Mum came, can he play intercity soccer? I said, I don't know, because I think I've made a mistake. I don't think this could be Pompe disease. He's running around and he's lively. He would come into our office and run up and down the corridor and jump up, and he didn't have Pompe disease. I said, I'm uncertain of Pompe diagnosis despite what we did before. And we insisted that he have a muscle biopsy. 3% enzyme activity. Diagnosis of the Pompe confirmed, the same mutation as his older brother. And completely normal histological data. Repeat muscle biopsy at 17 years, normal histology, still had 3% enzyme activity. And this is the younger brother, and that's his histological appearance at 7 years. And this is the older brother. At 2 years of age, this is what he looked like, and this is what the histology looked like at 17 years. These were the only two fibrotic fibers that the histological examiner could find. The rest of it, completely normal. And that was what we submitted to Muscle and Nerve and the other journals, and they said, well, it's not possible. And that's why we couldn't publish it until finally Muscle and Nerve. This was a meeting in California, or San Diego, I think it was, and this is the older brother, VD. He was now old enough to have his arms around 2 girls. He was then about, I think he was about 7 and he was about 17. And these standing patients are adult onset Pompe disease patients. These are 2 childhood onset patients, both of whom came to see us. This patient from Los Angeles and this patient from California. And they came once, and we told them what needs to be done. We never saw them again until this meeting. By that time, they were in a wheelchair, this with a trach and a respirator, and this one in a wheelchair. He was a bit younger, and ultimately the next year he was on a vent and so on. And here these two kids are, look at this smile on this kid. Okay, so enzyme replacement therapy for Pompe disease was introduced in 2007. Very effective. It was not introduced, actually, that's wrong. It should have been, was understood in 2007. We actually introduced it to the older brother about 10 years earlier, because autophagy came into its own and started to be understood in 2007, and it subsequently has become a very important catabolic aspect. Very effective in reversing cardiomyopathy. I'm sorry, let me just, I'm jumping ahead and talking about enzyme replacement therapy rather than autophagy reversal. Enzyme replacement therapy by Genzyme for Pompe disease was introduced in 2007. That's correct. I thought I'm just getting confused. Very effective in reversing cardiomyopathy, aerobic muscle fibers of severe infantile Pompe patients. So you end up with this severe hypertrophic cardiomyopathy which kills them, and that's reversed because they're type 1 fibers, but not nearly as effective in reversing skeletal muscle myopathy, particularly the anaerobic type 2 fibers, and particularly anaerobic type 2B fibers, which was demonstrated again by Nina Rabin at the NIH. This is the older brother at the age of 26, about 6 months ago, walking down the aisle with his wife, with his new wife, and his regular smile on his face, just a lovely young man. And nobody in the church at the time, except close family and close friends, knew that this boy had Pompe disease. And his younger brother was one of the groomsmen and walked down after him. Nobody understood it at all. There he is again with his new wife, and there I am watching very, very happily on the side. This is his younger brother, and just this was taken about 4 or 5 months ago, and he was in a dance performance in Aida, and one of the leading 4 people, and this is him here. Pompe disease, jumping up and down, very enthusiastic, normal muscle function. Here he is again. Okay, I missed him. Yeah, keeps jumping up. He's a jumper. Anyhow, then we saw another boy from California who had juvenile Pompe disease, and at age 9 in 2005, muscle biopsy confirmed diagnosis of Pompe disease, received enzyme replacement therapy for 5 years. But despite enzyme replacement therapy, he continued to deteriorate and came to us at age 14, where he had a muscle biopsy, progressive deterioration, and muscle weakness. At school, he needs to use an elevator to go up from floor to floor if there's a different class. Previous surgical repair of scoliosis, started high protein and exercise and nocturnal enteral feeding with continuation of enzyme replacement therapy. I didn't want to change anything except not 2 things at the same time, not to stop enzyme and to start something else and then you're not sure what's happening. We continued the same dose as he had been receiving, but we added high protein and exercise. Biopsy in 2012 for what had been happening for the last 2 years. He walks upstairs at school with a 10-pound backpack, no longer uses the elevator. There was a fire drill which he was always excused from. He just picked up his stuff and walked out to the field next door, just like everybody else when 2 years later on. significant increase in 6-minute walk and muscle strength, poor participation in social activities, in school activities including a 6-mile walk, and is scheduled to attend college away from home this year. There he is at age 14 when we saw him, and before high protein, and that's where you see his severe wasting with scoliosis repaired there, but wasting with the scapular spiking there. And this is age 16, and with a smile on his face because he's going to college and he's going to be living about 20 miles away, not living, sorry, he'd be going about 20 miles away and coming home each evening because Mum didn't feel comfortable in him handling everything, so she wanted to be on top of things. You've got to have the right mum. This is ZD's muscle biopsy at 14. He'd been on enzyme replacement for therapy for 5 years. 53% of the fibers are, here we see them up here. These are autophagic vacuoles, all these bits. This is normal muscle, autophagic vacuoles, 53%. This is it 2 years later. These are the only abnormal autophagic vacuoles there. That's all clean. The rest of it is clean, clean, clean. Okay, that was very, very informative, both clinically and histologically, how rapidly the process can be reversed. You remember the first child that we did it was VD, and we didn't really get a repeat biopsy for 7 years, and then it was completely clear. Clinical progression and muscle function deterioration of juvenile Pompe is identical to that of Duchenne dystrophy. It's early onset, early childhood onset, puberty usually wheelchair bound, mid-adolescent, respiratory dependent, die in late adolescence or early adulthood. As clinical investigation in Duchenne dystrophy, as illustrated by Brooke and their group in Muscle and Nerve in 1983, juvenile Pompe patients to undergo evaluation of baseline and at 12 months for the following, plus muscle biopsy that we proposed to MDA but were turned down. And what we wanted to do is to look at what we had just seen in this 2-year-old treatment of ZD and look at the muscle biopsy result, muscle strength, joint range of treatment, of motion, functional grade, time muscle functions, laboratory tests, and pulmonary function. I think that's it. Yep. Right. I don't know if we can get the video going or not. Maybe there might be some questions.
Yes. Si alguien tiene algunas preguntas mientras intentamos hacer funcionar el vídeo.
Sorry? I think I do, but I've forgotten where it is.
¿Alguien tiene alguna pregunta para el profesor Slonim?
Sorry?
Is there any questions for you?
We can put this in.
I can try if you want to go. I can do questions. I can try.
Yeah.